Well, welcome everyone. On behalf of the entire LAM Foundation, I am delighted to welcome you all to the debut of our LAMposium in Your Living Room webinar series. My name is Charlene Dunn, and I am the Patient Outreach Coordinator for the Foundation. And first, honestly, I just have to say what a fantastic turnout. I'm really excited and so excited to be here with everyone tonight. Thank you all for joining us as we bring LAMposium into living rooms around the world. A little backstory real quick. When we made the decision to cancel LAMposium, we weren't certain exactly what our next steps would be, but there was absolutely no doubt that we wanted to carry forward some of the inspiring planning and programming that we had originally scheduled to offer last weekend in Cincinnati. After all, we are celebrating our 25th anniversary of the foundation. It's just remarkable. So we reached out to our speakers, asked if they would be open to offering their presentation in a virtual setting. And what I can tell you about their responses, they were swift and generous and enthusiastic. And with that, LAMposium in Your Living Room was born. So thank you all again for coming together with us tonight. And with that, really, at this point, I would like to take the opportunity, and it's my full pleasure to introduce Allison Venugopal, who is our moderator this evening. Allie is our LAM liaison for Region 18, and that covers Alaska, Oregon, and Washington State. I first spoke with Allie back in the summer of 2017, kind of late summer. This was shortly after she was diagnosed and had been hospitalized in May. And it didn't take long at all for her to find her footing within our community. And she has been engaged and working her magic ever since. Allie is an outgoing and spirited and a whole lot of fun, and just really a pleasure to know. Grateful that she's here with us tonight. And Allie, thank you for helping us launch LAMposium in Your Living Room, and I'll let you take it from here.
Awesome, thank you, Char. The LAM Foundation is excited to kick off our LAMposium in Your Living Room series with our guest speaker, Mary Beth Brown from the University of Washington. Dr. Brown is currently leading a study that examines the impact of a home-based exercise program for patients living with LAM. She will discuss aspects of the study as well as the benefits of exercise in the LAM population. I'm eager to hear what she has to share with us this evening. But before we get started with Dr. Brown's presentation, I'm excited to debut a new segment that will be part of each of the LAMposium in Your Living Room presentations. It's a patient spotlight. And we want to focus on one patient that may or may not have had a chance to get to know many other Lammies. But today, this is a friend of mine who is here in Washington State, and she also has a connection to the exercise study that we're going to be talking about. I would like to introduce you to Emerald Erickson Mullinax. Emerald is a geologist who lives in Bellevue, Washington, which is just outside of Seattle. She was diagnosed in April of 2018 at the age of 35. I was lucky enough to meet her about 6 months later when she joined a group of local Lammies who were meeting up for lunch at one of our favorite restaurants, just the most amazing Chinese dumplings. It's one of our absolute favorites. I think we sat as a group, just 5 or 6 Lammies sitting together for 3 hours talking at lunch that day, and it was amazing. Since then, she's been an active part of our LAM community. I know she was looking forward to her first LAMposium this year. I know she's looking forward to getting together whenever we are able to get together, just so we can all get together and meet other Lammies. Emerald also has a passion for soccer. She started playing about 10 years ago when she and her husband joined a local league together, and she loves that they can share this activity and get some exercise together. With all of this, she was a great fit for the exercise study. She did her baseline testing on February 10th of this year, and then started the program about a week later on the 17th. Under normal circumstances, she'd be completing her exercise program that's part of the study in the gym and on the soccer field. But instead, she's doing this on the elliptical at home. She'll finish the program next week, but she's going to continue the exercises until she can go back into the clinic and do the post-study testing. Of working with the study, she said, "I feel better, and I'm so thankful that I'm doing this program to keep me exercising." I also love that when she was in the hospital after her diagnosis, a friend gave her a book of inspirational quotes, including one that she said really fits her. If you were born with the weakness to fall, you were born with the strength to rise. I love that. I think it actually fits a lot of us as well. And Emerald, thank you for participating in this research that's going to help us learn more about the best ways to exercise and to improve our health. This is one thing that LAM patients do really well. We jump at the chance to participate in studies so we can help to answer the questions that so many of us are dealing with. We're enthusiastic about asking the questions and then putting in the work to help the researchers and the doctors find the answers that we need. Thank you to everyone who participates, not only in this study, but in LAM research and in studies in general. Thank you for that. Emerald, as well as a few other women who have participated in the exercise study, are going to be part of our group conversation following this evening's presentation. And now, it is my pleasure to introduce our guest speaker for this evening. Dr. Mary Beth Brown is an associate professor in the Department of Rehabilitation Medicine, Division of Physical Therapy at the University of Washington here in Seattle. Her research is focused on exercise responses in patients and rodent models of pulmonary disease. Her past research helped her establish exercise recommendations for patients with pulmonary arterial hypertension and cystic fibrosis. After attending the LAM Foundation Patient Benefit Conference in 2017, which was also my first LAMposium, it became clear that there was an urgent need for research on exercise and fatigue in LAM. Dr. Brown is currently leading a study to examine the impact of a home-based mobile health exercise program for patients with LAM and to characterize skeletal muscle and skeletal muscle response to exercise in LAM. I would also like to say that I was privileged to be a part of this study, and I'm super excited to hear what she has to say. Welcome, Mary Beth. With that, I'll let you take it from here.
Oh, thank you. Thank you so much, Allie. I'm going to take over the share screen now so that you can hopefully see. Can you see my screen now? All right, let me get my slides going. And there, everybody good? You can see? All right. What I wanted to start with, first of all, is to thank Allie so much for that kind introduction, and Shar and Emerald. I'm so happy you were the patient that was spotlighted. That's so much fun to have somebody that's been in the study be spotlighted prior to a talk where we're going to talk about this study. So thank you to everybody. It's so moving that you are all on. What is our number up to? Shar, do you?
97.
198.
Gosh, that's amazing. Oh, thank you everybody for coming. All right, so we're going to begin really with a discussion about what we do know in terms of exercise and LAM. And then we'll spend most of the time, though, talking about what are the remaining questions, and then how we put together an exercise study to hopefully try to address some of these questions. And then we'll finish with a discussion of just preliminary findings so far from this study. So I'll begin, though, with a very obvious thing that most of you sitting here know already, but I think it's important to begin with it. And that is, we know there are health benefits associated with regular physical activity. That's been well demonstrated with decades and decades of good research looking at the outcomes, both short-term and long-term, of regular physical activity. And there's a lot of graphs like this in the literature, but I liked this one because this one on the right shows you daily sitting time against this moderate to vigorous physical activity. Because many of us have jobs where we're having to sit a lot of the day. And as you move towards the right on this moderate to vigorous physical activity scale, your risk for dying is called.
Yeah. Oh, go ahead. Yeah, this is Shar. I'm not seeing your slides. Could you try your screen share again?
Yes,
Yeah.
I will. I'm glad you told me. Let's try again. Now,
there we go.
Okay. Sorry about that. I'm glad you told me. Okay. Let me see if you can see. Is that better?
Yes,
Can you,
it's kind
you
of,
see? Okay.
Thank you.
Okay, sorry about that. Yeah, so as you can see on this little simple schematic, as you increase your moderate to vigorous physical activity, even if you do spend quite a bit of time sitting, as a lot of people do with their occupation, your risk of dying, your what's called all-cause mortality, goes down with increased activity. So as you move this direction. And as I was saying, the number of studies that have been published over the last several decades have clearly shown benefit in many areas. And this is not an exhaustive list, but this is a very recent list put together by the CDC just a few years ago. So things like reducing cardiovascular disease, reducing your risk of hypertension or type 2 diabetes, cancer, even things affecting our brains, so risk of dementia, how we feel, our quality of life, depression, so on and so forth. So many different well-documented benefits, right? So many of you would already know that or have heard that. And what you really want to know, is there any evidence that exercise is beneficial in LAM? And so I would be remiss if I didn't start with this study that was published a couple of years ago. And it was put together by a group in Brazil. It was a randomized controlled trial where they divided people into a group that received an exercise intervention in the form of pulmonary rehabilitation, and a control group where they were just observed during that same time period. And the time period was 3 months. In this study, they did baseline assessments, many of the things that I'll be talking to you about today, things to gauge fitness and strength, things to gauge lung function. And then after that 3-month period, they repeated all of those tests. And what that study told us, and it was really the first one that was a controlled clinical trial to look at exercise in LAM, what that study told us is that indeed exercise did show benefit in terms of exercise tolerance or ability to exercise. And an example of that is, or one way we gauge that is 6-minute walk test distance. I think probably everybody on here knows what a 6-minute walk test is. You've probably done multiple 6-minute walk tests. And so that number improved in the group that did the pulmonary rehabilitation, and not significantly in the control group. And also strength in the muscles that they tested also were improved in the group that did pulmonary rehabilitation versus the control group. Now note, above that are some measures of lung function. These changes occurred without any change in lung function. And you can see what I'm pointing to on the screen is called a p-value. And that is not significant because we're not less than, our threshold is less than 0.05. So you can see that lung function was essentially unchanged for most of the patients. Yet, despite that unchanged lung function, they had improvement in exercise ability. From this study, they concluded that exercise training, such as they did, increased endurance, and also, and this is endurance time on a treadmill. So these are individual patients and how they did at the 0 time testing or baseline versus 3 months later, and they showed improvements compared to the group that was the control group that did not improve or stayed or even went down in some cases. They also concluded that quality of life was better in patients with LAM when they participated in a pulmonary rehabilitation program. And this just shows a St. George questionnaire used commonly to assess quality of life, specifically in patients with pulmonary disease. And you can see that following the pulmonary rehab program, baseline is in dark, in black, versus the post, that symptoms went down, activity levels and their ability to exercise improved. And so overall, this study pointed to the idea that we can increase our exercise endurance and our ability to exercise, as well as our quality of life or happiness, by engaging in a regular program. So many of you have seen that study. I talked about it last year, and I think possibly even the year before that. And it's an important study, as I said, because it was the first one to talk about or to really test exercise in a clinical trial fashion. But I do want to bring up a study that was only published this year about yoga, and that this particular study showed that even involving yourself in a regular yoga program, like they tested in this non-randomized control study, showed an improvement in 6-minute walk test in a group that participated in yoga versus a control group who did just were observed. So that I bring up again because it's fairly hot off the press, and people are constantly asking about other things they can do and what the benefit is. So I thought you might be interested in seeing this yoga study. Now, despite that we know exercise is good for us, there is some evidence that patients with LAM are less physically active. And there was a study published in 2016 in a journal called Thorax that told us that the physical activity levels of patients with LAM, when it's assessed by number of steps per day or daily physical activity, or in as minutes of moderate activity, in all of those cases, patients with LAM had less than patients with COPD, chronic obstructive pulmonary disease, and when compared to healthy age-matched and gender-matched control subjects. And this was a very large database. I don't have the numbers right in front of me right now, but it was quite large, and I believe this is done actually in Germany. We're going to do a poll in a little bit, not now, but at the end, where I would like to hear from all of you if you get regular exercise. And by regular exercise, I will just use the guidelines of 120 minutes of moderate to vigorous activity. We're going to poll you, so you can be thinking about that now, of if you actually get 120 minutes a week, because I'm interested in the data for such a large group that we have on the phone or on the video chat. And since this is being recorded, we can actually use this. So think about that as I'm talking for the next 20 minutes or so. All right, so that is in a nutshell what we know, at least what we know from the literature. What are the research studies for exercise in LAM? We have a lot of knowledge gaps. And knowledge gaps are things that we really just need to put together studies to better understand. And one of those is, what is actually limiting the ability to exercise in LAM? What specifically is it? And the reason this is important is because you can think of exercise or achieving exercise benefit as this, if you've ever seen this game at the fair, where you have a hammer and you have to hit a platform. And you only hit the bell if you can hit that platform hard enough to make the little device go all the way up and ring that bell, right? So you can think of it as a threshold effect. Exercise benefit is well known to be something that you have to achieve a certain threshold in order to get. And that's frustrating because some of the limiting factors in LAM may make it difficult to achieve that level or that threshold of that's required for exercise benefit. And so that's really important that we understand what the physiological limits are to exercise in LAM. And they could be things like shortness of breath, referred to as dyspnea clinically. They could be things like fatigue, so tiring of the respiratory muscles or of the peripheral muscles. So peripheral muscles, we think of things like our leg and arm muscles. Also, though, our breathing muscles can be involved in that and could be a limiting factor. And then also just an overall fatigue, maybe not necessarily any one thing, but cumulative. And what we need to understand is, how do these different exercise parameters, so ways that we approach exercise, and then also tricks that we may be able to employ, like using oxygen or training in certain manners. How do those interventions or those approaches, how do those affect our exercise abilities in LAM, particularly if it's done over a period of time, as in training? And when we talk about different exercise parameters, what you will usually see discussed is how the exercise approaches in terms of frequency, how often somebody's exercising, how hard they're exercising, so how intense, what time, like what's the duration of the session, how long are they going, and then what type of exercise. So this frequency, intensity, time, and type, or the FIT principle, has been put forth for many, many years. And there's a number of groups that have studied, and I've got a few logos over on the right here, a number of groups that have studied different approaches to exercise in terms of frequency, intensity, time, and type for many different patient populations, as well as in individuals without disease, and have come up with guidelines based on those studies. And those are published, and you'll see them usually summarized something like this. This is an example from the American College of Sports Medicine published guidelines, where it describes the frequency, intensity, time, and type for exercise in terms of recommendations. So frequency, you'll generally see between 3 and 5 days a week recommended. For intensity, you'll generally see it described as moderate, but must be well-tolerated pace, and that those symptoms are that intensity is adjusted based on how a person feels. So rating of perceived exertion, rating of perceived dyspnea, shortness of breath, and their oxygen saturation. You'll also see recommendations for time to be starting moderately, something that's very well tolerated, and then gradually increasing that to 20 to 40 minutes. And that you can actually, more evidence recently has shown, you can actually do this in intervals throughout the day, and it doesn't have to be one big bout during the day, but it could be broken up where you are working towards that 20 minutes. And then for type is recommended for improvements in aerobic fitness, that you're doing exercise that targets large muscle groups. Things like walking or cycling or running if running is tolerated, or even different exercises in the water like swimming or water aerobics. And most importantly, things that are accessible and preferred. If you absolutely hate the water, then it would make no sense for you to approach exercise in something that requires you to swim or do something in a pool. So preference is important in that. So these guidelines, though, that I give you are very general, based on literature in patients with other cardiovascular and pulmonary diseases, and this is specifically COPD, and then also individuals without disease. And these have been around for a really long time. So in terms of how you should approach it, these are good guidelines to start with, to try, but I will not sit here and tell you that these have been tested for LAM yet, because they have not, and that's the reason I'm discussing it in our knowledge gaps, and that's what we are challenged to do. In terms of other knowledge gaps, we also need to understand what is limiting patients' ability to exercise that's not necessarily related to anything physiological. So I'm talking about things like just not having availability of rehab centers or exercise centers. And that's a very real issue, not just for individuals with LAM, but also people who don't have disease or are trying to get to cardiopulmonary rehab, and there's a really long waiting list, or their centers for cardiopulmonary rehab are so far away that it's not reasonable to get there on a regular basis. So limited availability is a real problem. And then also just time commitments. Other people, or everybody has a lot of things going on in their lives, and it's difficult to fit in sometimes. So trying to do it in a manner that is the most time-friendly is so important, and we don't really know what the best approach for LAM is that might allow us to reduce barriers. So reducing barriers to exercise participation is something that I've been interested in for about the last 5 years or so. I began investigating exercise in pulmonary hypertension in alternative models where we used things like mobile health platforms. And there's really nice studies published now, like this one sponsored by the American Heart Association, where this group out of Hopkins looked at a completely mobile-based program where patients were led with their smartphone and a Fitbit type device, and showed that they really could increase physical activity, and those patients could improve or gain some of the health benefits by following the program. And so that's been an interest of mine, and that was the approach I decided to take with this LAM study that I'll talk to you about now. So what are we going to do about these knowledge gaps? Well, what we really need to do, because there's a lot of knowledge gaps, is we need to prioritize the studies, right? We need to figure out what matters most to women with LAM. How do we do that? Well, there couldn't be a better forum than the LAM Foundation and what the LAM Foundation has put together with these with this LAMposium. And this is a little story I want to tell now that started a couple years ago, and how we came to have this exercise study. It really began, my first exposure was in 2018 when Sue invited me to come out to the LAMposium. And on that phone call, I had to very quickly Google LAM and better educate myself, because like many of physicians and even pulmonologists that you talk to, when you first mention LAM to them, they have to really think, wait, what is that? I know I've heard of it. Because it's not something you run into that much in the literature, certainly, and in patient care. So that was my first exposure. And then at this patient benefit workshop that was specifically devoted to exercise and fatigue, and this was at the LA meeting in 2017, a group got together, and you can see a couple pictures there of us specifically tackling these frequent complaints of exercise limitations and fatigue problems in LAM. And the group was made up of patients, researchers, clinicians, and physicians, a very broad group to discuss the problem and see if we could come up with some sort of research plan. And so a couple pictures from that, we literally started with sticky notes on a bulletin board. And this is a photo from that. And then this sketch is really light. This is actually my drawing. It makes me laugh now I look at it, because it looks like something a 12-year-old did. But it was a drawing, my initial sketch of a study that we might be able to tackle some of these questions that were on the sticky board, right? And so from that sticky board, we came up with some of our most important sort of areas that we had to tackle. Things like, my legs always hurt. Is this a peripheral problem? What is that? And then lots of questions related to limits of exercising with LAM. What are the oxygen saturation guidelines for exercise? And then what are those exercise barriers in LAM? And I love this that somebody wrote, so we can overcome them. That's awesome. That's right. And then this idea of developing some sort of app-based exercise program. So we took these and formulated some presentations at that workshop. And the presentations at the workshop really presented a lot of the ideas you'll see today with the study, which is, how can we collect some important variables related to exercise, but do it in a manner hopefully remotely as possible, so that people aren't having to actually come in to do exercise and for a lot of the collection. But also, how could we get at this skeletal muscle problem, this peripheral muscle problem? And this is a picture of a mitochondria down here, the energy sensor and energy factory of the cell. And really, is there something going on in the muscle that we could investigate at the same time? And that's where we had the idea of actually collecting muscle tissue, testing muscle strength, and running some assays related to muscle health, in addition to all of these other things that we wanted to measure. So that's where that all came from. And the result was a proposal to the LAM Foundation in their award category called the Patient Benefit Research Grant. And the LAM Foundation funded this. I'm happy to say we started the project only this past year. So I want to tell you our specific aims of the project, and there were 3 of them. And the first one was to determine if a 12-week home exercise program that was guided by an interactive mobile health platform with wireless app-linked technologies like heart rate monitor, pulse oximetry, activity monitoring, could achieve gains comparable to the only published trial of exercise for LAM that we have, and that's the study out of Brazil that I just showed you, in 2016, that was performed entirely as a supervised pulmonary rehab program. So again, I've already talked to you about my beef with, I love pulmonary rehab. I think it's a very important approach in patient care, but I also realize that it can be a limiting factor, and that we really need to test the ability to advise exercise in manners alternative to that. So that is why I decided to test this mobile health approach, so that as large a number of the population can have access as possible. The second aim of the project was to actually establish this mobile health platform by which patient-collected variables could be cataloged for the construction of a large-scale repository of LAM patient exercise and fatigue data that we can then utilize to optimize exercise and to try to study all of those factors that could be contributing to exercise intolerance and fatigue in LAM. So basically using what we're doing right now, collecting on a small number of individuals with LAM, and then opening that up to a much bigger collection process. And then the last aim, again, as I mentioned earlier, was to really look at what's going on in the muscles themselves, the skeletal muscles. So these are the muscles that move your limbs. What's going on with the muscles? Is there something that's different in patients with LAM? So is there an effect of the disease at the skeletal muscle level? And how does this respond to training, and how does this relate to functional outcomes in patients with LAM? And particularly things related to exercise intolerance and fatigue. So those were the three aims. A quick schematic of the study was that patients would only have to come in for 2 visits. So they would come in for a baseline test at day 1, and then not come back until day 90, approximately day 90, when we would do post-testing. So in between that time was a 12-week guided, a smartphone guided home exercise program and health monitoring program. The baseline testing and the post-testing is performed at a campus right near University of Washington called the Fred Hutch, which is a beautiful research-only center, the prevention center, where we are collecting our assessments. And then the home exercise program and the health monitoring is all done remotely. So individuals receive a Fitbit for the activity monitoring and the heart rate monitoring that interfaces with their phone, as does the pulse oximeter and their home spirometry device that we can collect weekly pulmonary function tests, as well as regular fatigue and shortness of breath surveys. So how was your fatigue this week? How was your shortness of breath today? Those kinds of things. And we're recording that on a daily basis. And so to give you a picture of what the study looks like, I'll run through some photos. You may recognize some of the people in this, slideshow here, covered by the pink box though. So this is actually the schedule, right out of the schedule that's in my Outlook calendar. And it takes a good part of a day. We're going great guns on collecting as many things as we can while an individual is there. So we start with getting informed consent that they want to participate in the study. They understand the benefits and the risks and what their rights are as a study subject. And then we do assessment of their vitals, their anthropometrics, so things like weight, body mass index, height, waist circumference, and then we draw some blood. Oh, and I want to give a shout out to Morgan Lee, who's a doctor of physical therapy, and she has been our study coordinator on this, and she has been invaluable in a lot of the logistics allowing this study to happen. And then subjects have a pulmonary function test, which I think you probably know what those are, right? What that testing is. As well as I think you know what a 6-minute walk test looks like. And this is one of the study subjects doing a 6-minute walk test. fine if you use oxygen, no problem. And it's just carried here, as you can see on this subject's back, like she normally does with exercise. And then a cardiopulmonary exercise test. And sometimes these are done on bikes and sometimes these are done on treadmills. We chose to do it on a treadmill because we wanted to use the results from the cardiopulmonary exercise test to help formulate the exercise prescription. So the exercise prescription is the directions for your exercise program, basically how hard you go, how long you go, all of that. And then in addition to cardiopulmonary exercise testing, where you get tested basically to see what your maximum is for exercise. In addition to that, we see what your maximum is for leg strength. Not just your maximum for what's called peak force, or how hard you can generate a force using that muscle. And in our case, we're studying the knee extensors. But also the fatigue profile. So we have a program that assesses how the muscle fatigues in a protocol specifically for measuring that decline over time, as well as power on a force detecting platform. After the strength testing and after lunch, then subjects are instructed in a home exercise program. And that home exercise program is very specific to that individual. So, and again, as I said before, it's based on your cardiopulmonary exercise test. So individuals will go for aerobic workouts 4 days a week, and then they'll also be given a resistance program to do twice a week. Again, all home-based. And the intensity is set based on their cardiopulmonary exercise test, where they get feedback from their heart rate monitor, their Fitbit, and their pulse oximeter. So pulse oximeter is measuring oxygen saturation at the fingertip. In addition to the home exercise instruction, patients are also instructed in how to use this home spirometry device to do a pulmonary function test once a week. So we can capture how that looks each week through the 12 weeks. And then just a picture of what a pulmonary function test readout would look like. Here's a picture of what our oxygen saturation data can look like second by second during an exercise session. So this is a period of 30 minutes. We have every second an oxygen saturation reading during a workout, as well as heart rate, and the heart rate's shown in the red here. And we have that for every single workout through the entire 12 weeks. In addition to that, we have every single day of physical activity in terms of the different categories of intensity. So vigorous, moderate to vigorous, and then just light activity. And as well as all the typical, number of steps and activity in terms of minutes and other measures of physical activity. Then after the home exercise program instruction, before the individual leaves, we do one more procedure, and that's to obtain a sample of their quadriceps muscle. And this is a picture of our surgeon that is doing this for us, obtaining a piece of quadricep muscle, and I put this up at the top here to give you some perspective of the size. So it's about the size of a quarter of a pencil eraser. If you can picture a typical number 2 pencil eraser on the end. It's about that size of muscle. And then some of you may ask what that's like. And I had this done myself, and this is my leg 2 days later. So you can see the tiny little, incision there, but no stitch. It's just covered with a steri strip that then comes off after about a week. So after the muscle biopsy and then surveys, like quality of life surveys, shortness of breath surveys, things like that, then we wrap up the visit. So that is, in a nutshell, what the study day looks like. And I want to give a shout out to our study team that you can see on the slide here. Morgan, the study coordinator, as I mentioned you already. And then I'm fortunate to be on faculty in the Division of Physical Therapy, where I have Doctor of Physical Therapy students who are interested in research and have decided to join this team, meaning that they will help with the data collection and the analysis, and they do this on a volunteer basis, which is really nice. So I have Missy, Julia, and Haley involved in this study, as well as a resident in our rehab medicine program, Amanda. And each of those individuals have taken a specific angle to this research. So, you know, we are collecting a lot of data. And I'm not going to go through and read all of these things to you, but what I want to show you is that there is so much data, we can really get at a lot of questions. So for example, Missy is interested in what's the effect of a mobile health exercise intervention, specifically on things related to physical activity behavior for patients with LAM, okay? So will they even adhere? How does fatigue and shortness of breath relate to them doing exercise, and how does that change over time? You know, menstrual cycle status, that's always something that patients talk about. Is there anything there in relation to how physically active they are and how they feel? So Missy's looking at questions related to physical activity behavior that we'll be able to answer, or at least take a stab at with some of this data. And then Julia is looking at how this intervention specifically impacts lung function. And so a bunch of sub-questions there, but again, all related to how does this exercise impact lung function itself in terms of pulmonary function tests and in terms of home spirometry and reported shortness of breath by patients. And then Haley is looking at oxygen saturation, specifically during exercise. How does oxygen saturation look in a patient with LAM during exercise? You know, when you're measuring it second by second. And also, how does this change over time with an exercise intervention? Does it change over time? So Haley's really going to be digging at those questions related to oxygen saturation. And then Amanda Wise is interested, she's the resident, said she was interested in quality of life, and specifically quality of life in relation to fatigue. She really wanted to study the fatigue variables as much as possible. So this study team has been wonderful because we are all coming together on a monthly basis and looking at the data and starting to pull out some answers where we can pull out answers. To give you some idea of our progress to date, we have so far, so we only enrolled our first patient back in September. In a very short period of time, we've collected quite a bit of data, I'm happy to say. And that is thanks to Allie, who has been unbelievable with helping me recruit subjects, and also just the motivated and giving nature of patients with LAM that I'm becoming quite familiar with now. So on a pretty rapid basis, this is rapid compared to clinical trials, this never happens. We have already, since September, enrolled, our goal is 15 subjects, and we've enrolled 10 subjects. And of those 10, we've already completed 6 individuals, and they've gone all the way through the study, baseline and final testing. And then we had one of those 6 that actually had to drop out due to personal reasons unrelated to exercise. So I feel really good about where we're at progress-wise. Our demographics, so of our 10 subjects, our average age is 49.2 years. You can see our body mass index of 24.3. Our lung function in terms of FEV1 and percent predicted, 55.6%. And also we have one individual on supplemental oxygen thus far, and everybody else does not utilize supplemental oxygen. Other preliminary findings, and I'm not going to show you a whole bunch, but I did want to at least point out that when we look at things like time on the treadmill, to give us an idea of how individuals are doing pre to post testing in exercise tolerance. Most people move in the upward direction, which is wonderful to see. And also we see that with 6-minute walk test as well. And again, this is data just shown for the 5 subjects that have completed thus far. And then some tests of muscular strength. So one of the tests that we're doing, in addition to the computerized testing, is we're just doing some very simple functional endurance tests, like a wall squat test, which has normative data associated with it. And we see quickly on this that 5 of the subjects that have completed that, all of them have improved in their muscular strength, at least as demonstrated by this wall squat test. What I'm most excited about, and I really can't share data with this yet because we just haven't analyzed it enough yet, but I want to tell you that I know and I hear a lot of the questions surrounding, a lot of the questions from you surrounding oxygen saturation. I know this is really important to everybody. And so this is probably one of the areas where we're going to dig the deepest in our data. And we have, as I told you, second by second data during exercise for the entire 12 weeks for every single subject. And so with that data, what we're doing then is binning it, and this is just an example of week 1 for a subject, of binning their time that they spend in what would be labeled clinically as very severe desaturation versus just moderately severe or mildly severe desaturation, in terms of where they go between 100%, 99%, all the way down to very severe, which is down in the low 80s. So we can capture that type of profile, and then we're going to analyze how that changes over time, or if it changes over time, and most importantly, how does that relate to how subjects feel? Because honestly, when you ask questions about oxygen saturation and exercise, the answer that you get will depend greatly on who you ask. And that is because there is not any solid evidence for exercise saturation levels in really many cardiopulmonary diseases, but especially in LAM, because it just hasn't been studied in this manner. So I'm really excited that we'll be able to contribute this after this study is complete. It's I think, one of the most important things that will come out of this. And in talking with my pulmonary medicine colleagues, this is honestly what's exciting them the most as well, is getting together and looking at this oxygen saturation data, because I think that's going to tell us a lot about how to set exercise guidelines. Again, though, I want to come back to this graph of where we are with subjects enrolled and say, we need you. We want to hit all 15. So I need to enroll, I'd like to enroll 5 or 6 more subjects. So if what you've seen is interesting to you, please reach out to me, or you can reach out to Allie, and let's at least have an email conversation and then a phone conversation and see if it makes sense to you to participate. The last thing I want to say, this picture was put in here to remind me, COVID has not destroyed the study. It is trying to, but it is not. We're not letting it. What we've had to do because of COVID, we have 4 subjects who are not allowed to come in for their baseline or their final testing until we can reopen the center again. We are told that June 1st, we are able to do that. So we are fingers crossed that that's going to happen. And fortunately, all of the patients enrolled to date that are in this sort of holding pattern have been awesome to say that they will keep up their program. And that way we can make sure that we're not losing those gains that they've made before we can retest. We have also been creative to capture some endpoints remotely. And this is a picture of one of our subjects' husbands who has set up a 6-minute walk course outside their house in a flat area where they felt that they could do this safely. And the husband is the clinician here, timing and capturing the data for us. So we're doing creative things like that. COVID's not going to put a damper on our ability to collect our study data. And that's all I have for my presentation. I'd like to first of all, thank you for your interest in this. I'm blown away by the number of people on this call, and I'm so thrilled. And then secondly, as you know, we're going to have a question and answer session now. So let's do that. And before we start the question and answer, let me see if I can stop the share here and pull up the polling. Can you see this poll, everybody?
We can see it, Beth.
You can see it. If you don't mind, since this is being recorded, I would love to just get a, this is casual. It's, yes, I realize it's not stringent, but I would just love a feel for what our group does in terms of exercise. And let's just give it 1 minute. So we're at 30 seconds now. So if everybody could try to get their answer in that wants to answer in the next 30 seconds, that would be great. And then I'll end the poll. And just in case that's not saved, I'll write it down when we get to a minute. Oh, I see a chat thing here, pre-COVID-19. I know, definitely, yes. You can make this your pre-COVID habits, because I recognize that this has really thrown a wrench in some people's exercise plans. And we're at a minute, so I'm gonna write down what we have. Looks like the answers are still coming in. 37%. All right, I'm gonna end the poll there. And I think I can share the results with you now. Let's see. Can you guys see this? That's what we look like.
Yeah.
Cool. Okay. I don't want to take up any more time talking. I want to open it up to questions now because I realize we ran over just a bit. Let Allie take it over.
Perfect. Beth, thank you so much.
Yeah.
That was incredibly interesting and informative. And I know there have got to be quite a few questions that are going to be coming up. What I would like to do is invite everyone to see that the chat box is going to be opened back up. If you have a question, please type your name, just your first name and maybe a last initial, and don't type your question, just type your name in the box, and we're going to go through and I will call on folks and invite you to ask your question. Because we want to try to get to as many people as possible, please just ask one question at a time. And if you do have another question, feel free to put your name back in the chat box and we will cycle back through. We're also going to be adding in a few questions that have been sent in via email because we do have some LAMI sisters who are overseas where it's in the middle of the night and they aren't able to join us. So while we're getting everything set up with the chat box, why don't we start first, Beth, with a question that came in from Sarah P., who is overseas. Her question is, at the beginning of a cardio workout, my oxygen saturation levels drop quickly, but then after a couple of minutes, they bounce back and stay higher throughout. Is there a good warm-up you recommend to ease into things a little more slowly to try and stop this?
That's a great question. That was from Sarah.
Sarah, yes.
Sarah, yeah, this is a really common, there's probably a lot of you nodding, those of you who measure your oxygen saturation during exercise going, yeah, I noticed that too. So that's a phenomenon that we see not only reported in the literature, but also we see it with our own study subjects when we're doing an exercise test and we're measuring oxygen saturation, that there'll be, as exercise is initiated, there'll be what would be one of the most drastic drops, and then a gradual recovery of that, and then a steadying out. And that can be a little bit better if you do a dedicated warm-up, and a warm-up may be different than what you might be thinking of warm-up. So sometimes people think if they're gonna go moderate to vigorous, they might do a really easy walk for the first few minutes, and then they go into whatever their intensity of exercise is going to be. Try instead really intentionally graduating that effort. So for example, an easy walk to an easy walk with bouts of faster walking, if your intention is to be at a fast walk. So having that gradient rather than a, couple minutes and then boom, start. We've seen that patients, when we do a more gradual warm up when we're testing, that initial big drop can be reduced, and you may find that yourself as well when you're measuring your own oxygen saturation. So a little bit longer and a little bit more graduated warm up would be a good thing to try.
Okay, thanks, Beth.
Mm-hmm.
And it looks like we've got several folks who are ready with questions. Why don't we start with Itzel P. If you can unmute yourself and ask your question, please. Itzel, are you able to hear and possibly just unmute your audio so you can ask a question?
It's in the, in the lower left corner of your screen, you'll see a little microphone button. It probably has a red slash through it right now. If you can just click on that, it will remove that slash.
Yes. Hi everyone.
Hi. There you go.
Hi.
I usually practice Pilates, and my instructor is a physical therapist. Mm-hmm. And she told me that when we have a pulmonary surgery in our lungs, the muscles usually tied up and reduce their size. And when we practice Pilates or yoga with the correct breath phase, we will be able to correct the size to the normal side of the muscle that they are around of the lungs. That is right or not?
Yeah, that's a great question. How do you say is it Itzel?
Yes, Itzel.
That's a great question, Itzel. And yes, in pulmonary rehabilitation, there is always a respiratory training component, or almost always a respiratory training component. And that is because there is a lot of evidence through research studies and clinically that dedicated effort to practice and improve breathing technique actually does make a difference in breathing or respiratory function. So you'll see that included in pulmonary rehab programs, but I think that it's wonderful that your Pilates instructor is recognizing that that's actually a benefit of some of the work that she's doing and could be part of the explanation for the improvement. Remember that yoga study I talked about? Some people will look at that yoga data and say, wait a minute, how is yoga actually improving exercise performance? Well, one of the ways is probably because of its effect on the breathing muscles themselves. So that's very true, and I think it's wonderful that that's been brought up by your Pilates instructor. And
yes, in fact, the thing that made me decide for that studio is because all the instructors are physical therapists.
Yeah,
so they know the entire body, all the muscles, mm-hmm. and they have all the file of your medical information and mm-hmm. what do you have to work in your body. In my case, is my upper side with my lungs and my breathing, and I think that is improving better and better because I just started to do cardio walking inside of apartment. Mm-hmm. And I did not use a bronchodilator, bronchodilator.
Inhaler,
So I think my breathing is improving because of the Pilates.
I think that's wonderful that you're recognizing that and using and including that component. So that's fantastic.
I agree. Itzel, thank you so much for your question. And I have to say, Pilates is one of my favorite ways to exercise too. So I love it. How about a question from Melissa M? Melissa, can you unmute?
There we go. Now I'm unmuted. Hi.
Hey.
So, just curious, I am really brand new to this diagnosis. I just got found incidentally back in December and confirmed pretty much in February. So I am a long distance runner. I've been running for most of the last 5 or 6 years, I guess I would say. Is there any evidence that you're aware of that running could like be beneficial to the progression of LAM, or if it could cause harm? I mean, my biggest concern at this point is, would vigorous running have the potential to cause more harm than good for my LAM? So like I said, I'm kind of brand new to this diagnosis, and I really don't want to give up my running. It's like my thing that I do.
Yeah, no, that's, Melissa, that's an important question, is you always need to examine that cost benefit ratio, right? And so with you, running is something you've done for a long time. So while running seems like that's incredibly intense for you, since you've been a runner for years and years and years, that's more moderate level of exercise for you, right? And we have had study subjects who, when we give them their exercise prescription that's based on their cardiopulmonary exercise test, they actually have to run in order to achieve that level that they've been prescribed. So for you, running may be perfectly appropriate intensity, whereas for other people that may be too much. So I wouldn't want to answer your question and say running is great and everybody should do it at that intensity, because that's not the case with exercise, right? It's not a one-size-fits-all approach. What you should be especially keen to is your symptoms, right? And so you shouldn't feel worse. I mean, that's kind of a no-brainer, right? But sometimes people forget that in their quest for making progress. You will, that extra phlegm and that extra coughing and I felt terrible later that night and that next day. No, that's not good. So you really do have to pay attention to what your body's saying to you on whether it's too much or not. But I would never say to you that running itself is too much, because again, for you, it probably isn't. Now, obviously, I don't know you personally, and I haven't, tested your cardiopulmonary capacity, but just from what you've said, it sounds appropriate to. Again, symptoms really have to guide how you're feeling. I will say one more thing, and that is this idea of how hard people go, how much their O2 saturation changes, and how they feel later is really important to me, as I've mentioned to you. Like, this is, I think, one of the most important things that's going to come out of this study. So I can't answer those questions yet, but know that I'm really going after it, okay?
Cool, thank you.
Mm-hmm. Awesome, thank you, Melissa. How about a question from Beverly H?
You have to unmute me. Oh, there we go. Okay, sorry.
Hi, Beverly.
Hi. I put my question in so other people could see it, so I'm there twice. But I was wondering, when you do the study going forward, if you do it with people on oxygen and people not on oxygen, because it's two very different,
Yeah.
very different symptoms, and the levels of oxygen. When you're first on oxygen, when you're later on oxygen, so the levels and the energy is totally different than when you're first diagnosed, or even not when you're first diagnosed, when you're not on oxygen.
Yeah, you hit the nail on the head, Beverly. You're exactly right. And for this study, and it's kind of what we call an all-comers approach, because I'm just trying to really do this initial collection. But then in later studies, you can fine-tune things like what you've just said. Because certainly the response, and we see that with patients who will do an exercise test without oxygen, and then we'll do the exact same test with oxygen, you can see very different physiological responses. Mm-hmm. Some of you may have even had that done before your decision and your physician's decision to prescribe exercise. Sometimes they do a repeat exercise test, one without oxygen and one with. and they use that assessment to decide oxygen recommendations. So you're right, for sure, Beverly. Thank you for that comment.
Okay.
All right. And Beth, why don't we take one more question that came in from some of our overseas sisters.
Okay.
Here's the question. Some activities cause my oxygen saturation levels to drop lower than others, even if it feels like I'm working at the same exertion level. Things like lunges and other activities where I go up and down cause lower drops. Is this for a specific reason, or is it different for everyone?
Yeah, good question. And probably a lot of people listening to this that do things like lunges and squats, and if they're measuring their oxygen saturation, are probably nodding their heads and saying, yes, I observe the same thing. And the reason for that, the simplest explanation, the most likely explanation, is that things where you're moving your body up and down against gravity, like lunges, like squats, like sit to stands, any of those types, stairs, those utilize very large muscle groups. And not just very large muscle groups, but a lot of them at the same time. So the more muscle groups that are involved in an exercise movement, or any activity really, you know, picking groceries up and taking them up a few steps into your house, anything that uses a high number of muscles to perform, even if it's a short period of time, pulls more oxygen, because remember, for that muscle to have the energy to contract, it has to utilize energy as a source of, or utilize oxygen as a source for energy. So that's why you'll see differences based on the movement that you do and how much muscle group is involved in that activity. Does that make sense?
Okay. Yes, it does. So thank you.
Mm-hmm.
How about a question from Shay G? Shay, are you able to unmute?
Wow, it's a weekend breakfast with Nutella. Nutella goes with pancakes. And sleeping in with waffles
And
smiles.
Shay, if we're not able to catch you right now, maybe we can try one other question and then circle back and see if
can you hear me?
Oh,
Can you hear me
perfect.
now? Okay. Hi. So I had a question. When you're doing the testing for your study, are you also testing for iron deficiency, anemia?
Yeah, we are collecting blood, and we certainly could look at that. That's been brought up since it's a known contributor to fatigue, or the perception of fatigue. So it's not in the plan right now, but we're basically banking those samples of blood. So as we, obtain interest from other groups that are interested in looking at things, that certainly could be something that we look at.
Yeah, because I've been a runner for most of my life. Mm-hmm. And this past January, I tried to pick up running again, but halfway through my exercise, I was getting so short of breath and so fatigued when I shouldn't have been. And at my LAM clinic meeting in March, it was discovered that I had iron deficiency anemia, which is probably why I was so short of breath.
You know what I think is wonderful? That clinic didn't immediately write those symptoms off to your LAM and actually dug and looked to figure out if there could be something else. That's awesome. And everybody listening should remember to be an advocate for yourself and make sure that you feel like your caregivers and the clinicians working with you are really thinking about anything that could be impacting the symptoms that you describe. So that's great, Shay. Thank you for sharing that.
Thank you.
I see Susie Picard asked a question on the chat. I can't wait. She said, do you have or can you share any info found on skeletal muscle samples? Is there a difference between LAM patients and those of, quote, normal women? And Susie, that's a great question, and I am excited to look at that, but I'm waiting to run all of those assays until we have everybody collected. So hopefully you'll hear me speak about that at the next LAM meeting.
So, and thank you for grabbing that one. I knew
Sure.
Susie's question was coming up. And I think we've got time for maybe one more question before we move on to we're going to have a group discussion after this. But how about a question from Karen K? Karen, if you're here with us.
Okay, my question is, in your study, Mary Beth, the 6 people, only 1 is on oxygen, but the average FEV1 is 56%. I find that very interesting since I'm on oxygen 24/7 and my FEV1 is about 50%.
Yeah, we actually enrolled a fairly, what I think our average age was 49. And what I didn't show there, I didn't show, because I didn't gather it in time, the time since diagnosis varied, but we had a number of individuals that were fairly recent in their diagnosis. So, you know, it's really not just a single pulmonary function value, but it's multiple things. And as of now, that's how it's laid out, that we've just had 1 that was on oxygen. But as I said, I'm interested in individuals who are on oxygen as well as not. So I'm hoping that there may be some individuals, you know, on this call that might be interested in the study.
Okay,
So,
thank you.
But part of that could have been that we had a fairly young in terms of the disease process.
Okay, okay.
Karen, thank you for that question. And I know we do have several folks that would like to be able to ask questions. I also know that we do have a group chat that's coming up in just a few minutes, so maybe we can discuss some of those questions together as a group. But right now, I would like to thank Dr. Brown for being with us tonight and kicking off our LAMposium in the Living Room series. We really appreciate such an informative, educational, and just interesting presentation.
Thank you.
You know, again, I was fortunate to be part of this study, and I learned so much. Just even, I thought I knew quite a bit about the study, and I learned a lot more tonight, so I really appreciate that. We really do appreciate you bringing to us the same information that we would have been able to hear from you in Cincinnati at LAMposium.
Yeah.
And on a personal note, sorry, Beth?
Oh, I said thank you, Allie. And the only thing I wish is that I had more data to share now, but I know that that's coming. So
yes,
so that's
I'm looking forward to seeing it.
We'll have you back.
And on a personal note, I just wanted to thank you for allowing me to share in this experience with all of you. I had a blast with this.
Cool.
Beth, thank you for all of your hard work on the study. I really enjoyed participating and just learning about my own limits and kind of surprising myself with some strength that I didn't realize that I had. While I was looking forward, like everyone else was, to getting together and doing everything in Cincinnati, I love that we can still get together just in our living rooms, learning from our researchers and doctors, and most importantly, just being together as a group of LAMI sisters and loved ones. This community is one of the strongest that I know, and it has meant the world to me personally to have such a strong support system just for me as we all navigate through this journey together. Thank you to the LAM Foundation for making this happen for all of us. And before we go over to our group, we're going to essentially open it up and just have a group chat with everyone who would like to be able to stay. I'd like to toss it over to our fearless leader, Sue Sherman, for just a minute. Sue?
Hello, thank you, Allie. Listen, I am going to unmute all of you so that you can give Dr. Brown a round of applause, because that was fabulous.
Thank you.
Yay.
Well done. So that was, we rarely went below 190 people for the entire session. I think the single largest LAM patient educational session. When we're all together in Cincinnati, I get to say who's in the room, and we have 10 countries that I could count on the call tonight. So I at least grabbed Guatemala, Argentina, Brazil, Panama, Mexico, Russia, Australia, Canada, and more than 25 states and the District of Columbia in the USA. So welcome everyone from around the world. That's extraordinary. And we're hoping that even more people will be able to watch this now that it's recorded. And again, the LAM Foundation is heartbroken that we could not be with you in person in Cincinnati, but this makes it all worth it, and we are looking forward to doing this every month, maybe forever. You know, maybe this is our new way to provide education to more and more people around the world. We have Women with LAM, we have doctors, dads, husbands, sisters, moms on this call, and I think my favorite quote was when referring to exercise, Beth, you shouldn't feel worse. We could probably all take a lesson in that we shouldn't feel worse, we should feel better when we exercise. I just, again, want to end by saying this is your foundation. This is your forum. 3 years ago, you women just like you filled out a survey and you said what was important to you was learning about exercise and learning about fatigue. And so we took what you wanted, we made a conference, we raised money through all of you, gave that money to a talented scientist who is innovative and fearless and is making this happen. And now you're actually seeing the real-time results, and hopefully your lives will be improved by it as we progress with where this study goes. So I encourage you to stay in touch with us, tell us what you need, we will respond. And if there's any testament to how powerful you are, yesterday for Giving Tuesday Now, we all together raised more than $60,000 in less than 12 hours with a beautiful challenge grant from the Hoy family. And that will fund another couple studies just like this. So I will pause with that. Let you all try to navigate a chat room with 158 people in it. Good luck.
We're on it.
I thank Shar for your hard work and the entire LAM Foundation staff for making this happen. So have a beautiful night, and thank you to everyone for staying on the call.